Okay, welcome folks. This is the VCU Department of Internal Medicine Grand Rounds. My name is Christian Bergman. Today is September 5th, 2024. It's a new year for Grand Rounds, and for those of you joining us in person, we are in a new location. We are down at the Molecular Medicine Research Building, which I have not been in this building before. It's actually a wonderful location, and I would just call attention to folks, if you leave the room, if you are not aware of St. Philip's Walkway here in the Academic Square and the monuments and buildings around us, I would pay extra attention to that as you leave Grand Rounds today. There's a lot of history just a few steps away from our building. So happy to be here, Molecular Medicine Research Building, first floor, room 1009. For those of you joining us online, thank you for tuning in. It will be every Thursday from now until June, with a break for Thanksgiving and Christmas. All right, so today's speaker, the topic today is artificial intelligence in medicine, the good, the bad, and the surprises. We are pleased to invite Dr. Robert Hoyt to talk to us today. Dr. Hoyt graduated from the University of Virginia and then attended medical school here at VCU, where he received his medical degree, followed by internship and residency in internal medicine. After 3 years in the Army, he began private practice in Virginia for 15 years. Following that, he returned to active duty in the Navy, where he finished in 2009. During this time, he also conducted research at the Navy Aerospace Medical Research Laboratory and the Robert E. Mitchell Center for Prisoner of War Studies, located in Pensacola, Florida. Additionally, he taught health informatics at the University of West Florida for 10 years. He's the editor and author of Health Informatics, the Practical Guide, which is now in its 8th edition. He's also editor and author of the Introduction to Biomedical Data Sciences, published in 2019, Data Prep and Exploration, published in 2020, and No Code Data Science, published in 2023. In 2014, he became board certified in clinical informatics, and in 2016, became fellow of the American Medical Informatics Association. He's on the board and faculty for the American Board of Artificial Intelligence in Medicine board course review study, which he's taught for the last 4 years. And he had reached out last year and really wanted to come here to VCU to share his knowledge and network with you all. Before we welcome Dr. Hoyt up here, I want to welcome Dr. Fadi Saloom up here, who's been working on the research. Dr. Saloom is our chair of research in the department, and he's been working with Dr. Hoyt on some interesting projects and wanted to say a few words. Come on up.
Thank you, Christian. Good afternoon, everyone. Before we turn it over to Dr. Hoyt, I just wanted to extend our gratitude and thanks for him sharing his knowledge, this really rapidly moving and important field. I would also like to announce for all of you who are familiar with our pilot program within the Department of Internal Medicine that's been running for several years, with the generosity of Dr. Hoyt and his passion for this field, we are pleased to announce, and please keep your eyes open for the call for application that should be coming out in the next week or so. There will be a new pilot announcement for AI in medicine, data science or AI. And Dr. Hoyt is supporting this endeavor, and we hope to keep growing the interest within our department and with the new themes, with the data science informatics theme that now will be hopefully going across the departments within the School of Medicine as we keep reimagining the integration within between our departments within the School of Medicine. So Dr. Hoyt, I'll turn it over to you.
Well, thank you for that kind introduction and the opportunity to come here and speak. If you're surprised to see me back, the surprise is mutual. Had someone told me 50 years ago that you would be back here talking on artificial intelligence, my first thing would be, let me see your medication list. Obviously, we need to tweak something. But I'm here, and the field, for you younger people, the field of medicine is amazing. There's so many horizontal and vertical opportunities that you can take advantage of. I had just a couple of announcements, though. First thing is a shout out to two people. One is my wife, Ann, who's in the front row. She has tolerated 15 years of data science, AI, machine learning in lieu of retirement. And maybe my son said it best when he said, retirement's for quitters. So I have not retired. And the second one is Jody Smith. Without Jody, who's your director of development, by the way, without Jody, I would not be here. She has kept us up to date about changes in manpower, needs, you name it. And that's been our conduit, our connection to MCV/VCU. So we're very indebted to what Jody has done for us. So the other thing, a couple other things, I made all of my slides available for this talk and also for the workshop. And I've given all my contact information as well. Now for the workshop, let me just comment a little bit about what that's going to be. During this time, I'm not going to get in any technical details on like artificial neural networks. That would bog you down forever. I am going to be talking about some free open source data science programs I use all the time. I'm going to talk about a medical literature summarizer that I use all the time. I'm going to talk about a new AI data analytics package that's really quite good. And lastly, I'm going to show you all how easy it is to build your own medical chatbot. And I'm going to use actually 2 clinical practice guidelines by Dr. Sterling to show you how we can synthesize that information, complicated CPGs, and make it very palatable, if you will. I have no conflicts of interest to report in terms of what I plan to present. I'm going to give you a little bit of history and background, some general concepts about AI, talk about predictive analytics versus generative AI. I'll give you use cases of both. I'll drill down a little bit further with large language models. We'll talk about some of the challenges and limitations of AI. And lastly, some surprising discoveries, some things that AI does that we can't do. So this slide just simply shows you that you may want to bury your head, but you really can't. And that pretty well in the lay press, everything you touch has an AI element these days. The September issue of JAMIA was devoted to large language models, but spoiler alert, it's not clinical. It's not very helpful for most of the clinicians, I'll say up front. Okay, let's talk about the history, which I find very interesting. I'm going to argue that Alan Turing, in a way, started this out. He was the guy that was involved with solving the Enigma machine and whatnot, but more than that, he saw the future. He saw that computers were eventually going to be powerful, and probably he was talking about AI when he said that, and he developed the Turing test. So that's who I'm going to attribute the initial work to. Secondly, in '56, John McCarthy coined the term AI at a conference. The next year, it's kind of interesting. The perceptron, which is basically a real simple neural network, was introduced by, of all things, a psychologist, not a computer scientist. And interestingly enough, one of his colleagues then said, oh, that'll never work. And that was one of the first AI winters where everybody went, well, he said it wasn't going to work. He was wrong. It was really good. So in 1972, Ted Shortlift, who's an internal medicine doc, introduced the Mycin project, which I don't consider necessarily AI, but what it was expert systems or rules, if-then rules. In other words, if the patient is septic and has a rash and has this, then it's likely to be staphylococcus, let's just say. But remember, he had no internet, he had no cloud computing, he had nothing. Shortly after that, you were starting to see convolutional neural networks. That's what CNNs are. Being able to suddenly analyze images, but it was quite crude. It was when we got GPUs, graphics processing units, and we got that from the gaming industry, interesting enough. That was a quantum leap forward. Notice the gap again to 97. Nothing was really happening in AI. And then IBM got involved with Deep Blue and defeated the chess champion. And then again, a gap. 2011 was the Jeopardy champion. And then Watson, though, kind of had its issues. Watson Oncology never quite performed, and that was kind of an IBM winter. And now you have Watson X, which I don't know enough about. But fast forward, let's go to another gap. 2016 was a big year for Google DeepMind. Well, AlphaGo is probably the most complicated Asian game there is. In fact, if you talk to a Go expert, they can't tell you what they just did or why they did it. But using deep reinforcement learning, again from the gaming industry, and training for 2 years, they were able to beat the Go champion. AlphaZero the next year, even better. 2017, another quantum leap, this time in natural language processing, when they developed transformers with attention mechanism, a way to analyze words and sentences and paragraphs rapidly in multiple directions. And it just was, again, a quantum leap forward. In 2020, we saw AlphaFold by, again, Google DeepMind, which predicted three-dimensional protein folds. We're up to AlphaFold 3, and I'll comment a little bit of that on another slide. 2022 was the beginning of the generative AI with GPT 3.5, and later 4 and 4.5 and 23. And 24, we now over 1,000 large language models, also becoming multimodal. And GPT-5, also known as Project Strawberry, is right around the corner. I can't give you a whole lot more detail because nobody knows. These are eras that I created that you can argue on your own whether you agree with the timing. But the point was there was early AI, then machine learning. Suddenly you're seeing random forest, XGBoost, all these new algorithms. Modern deep learning, again, was with more complicated neural networks. Now we're in kind of an era which is really part of deep learning, but is generative AI, and I'll spend a minute on that. So AI, you can define a lot of different ways. This is one of the simpler ones. Any technique which enables computers to mimic human behavior. Machine learning is all about predictive analytics and learning patterns from data using algorithms. Deep learning, again, is more complex neural networks with multiple hidden layers. And last, generative AI, which is part of deep learning, is, again, being able to generate text, interpret text, generate images. The most common example of generative AI would be large language models. There are at least 3 driving forces of why we are where we are today. One of them is better techniques like CNNs and transformers. Better storage. We now have not just enterprise relational databases, you've got graph databases, you've got data lake houses, you name it. And lastly, it was a huge big deal when we started getting GPUs, which continue to get better with NVIDIA. Just a little bit of an aside is we use the term AI, artificial intelligence, all the time. The AMA would prefer augmented intelligence. They view that as less threatening, and it's kind of the overlap between the two. But I think we get into a definition problem is, are calculators augmented intelligence? Should expert rules still be considered part of AI? Stay tuned. And then the other one is narrow versus general AI. Narrow AI is primarily what you've been seeing. You train a model to pick up a benign versus a malignant breast lump, let's say. And that's all it does, though. It's very narrow. And most AI today is narrow. Even things like analyzing retinal images, that's narrow. It can't do anything else. But we are slowly moving towards general AI, which can be autonomous. It can reason much better like a human. It does many more things, and it's multimodal. Well, guess what? We're now multimodal, analyzing text, audio, visual, images, and whatnot. But it raises a lot of questions. Does AI generate information, knowledge, or wisdom? Believe it or not, there's no consensus on that. I'm going to argue it now has some knowledge. So again, when will we see artificial general intelligence? The experts estimate anywhere from 2 to 30 years. You pick the number you like, but I think it's going to be sooner rather than later at the rate we're going. This is something to point out that you all probably have seen this data to wisdom pyramid, but what if now intelligence is integrated? Let me give you an example. Data is just a number without significance, let's say. Let's pick the number 7. Information is data with meaning. So the number 7 is prostatic specific antigen, or PSA. Knowledge is that's abnormal, it's elevated, but it also knowledge that, well, it could be a false positive. And wisdom would how you deal with it, but intelligence would be something like the following. This is a 50-year-old African-American male, as a reminder, and prostate cancer is not only more common, it's more virulent, and the PSA is less reliable. So that's embedded in the electronic health record saying recommend urology, referral or whatever. But the point, that's how a lot of us see intelligence embedded. This monstrosity, just I'll cover real quickly, and I'll cover it in the workshop, is just the way machine learning, again, today is primarily predictive analytics. If you're predicting something that's categorical, like lived, died, intubated, not intubated, that's classification. And that's the most common type of machine learning today, predicting that. If you're predicting something numerical, length of stay, life expectancy, that's regression. And then reinforcement learning I mentioned is from the gaming industry, and unsupervised learning is very interesting and under-leveraged. Unsupervised learning is when you don't know the outcome. That data is not labeled already sepsis and non-sepsis and so forth. You're just looking for interesting patterns and relationships. It got started in the genomics industry, or field. You could understand where you're suddenly looking at this avalanche of genomic data, not knowing what to do with it. So one of the first things you start with is unsupervised data, then you find clusters, and then you analyze the clusters. So that's all the time I'm going to spend on that. So deep learning is neural networks with multiple hidden layers. Computer vision or image analytics is convolutional neural networks primarily, but now like GPT-4o does a good job of analyzing images. Generative AI, I've mentioned, is largely transformer based. And again, you can get text to image, which is diffusion, transformer, and GANs. But a reminder that computers really analyze ones and zeros. They cannot analyze text. They can't analyze an image. It has to be converted. Now, there's no secret that there's been an explosion of data in general. The plot on the right deals with worldwide all data, and it projects up to 2025, and that's in zettabytes. And a zettabyte is 1 trillion gigabytes. Last time I checked, that's a lot. And the doubling time of medical knowledge is getting to be fairly scary. The most recent timeline I could find was 73 days. The articles published in PubMed double every 5 years. So the question really is, how in the world would you deal with all of that data without it? So the goal, though, is to take data of multiple different types, multiple different origins, so multimodal big data, if you will, that is uploaded in the electronic health record and databases. You apply artificial intelligence, machine learning, deep learning in order to improve personalized medicine, to be able to drill down to the individual for the first time, and all the omics, if you will. Now, predictive versus generative AI. Predictive analytics is really what we initially began with. Let's take, for instance, images, where we're trying to classify a nodule in the lung or breast or whatever as benign or malignant. And it's trained on thousands of normal images and thousands on abnormal images. That's predictive AI, and it would do it with tabular data that fits in a spreadsheet. But along comes generative AI that's trained on so much. As an example, GPT-4 has 1.76 trillion parameters, training parameters. That's unbelievably huge. So we're in an era with generative AI where it's text to anything and back. So that's what you're seeing right now. And this is an example in PubMed. If you look at AI in radiology, which is largely predictive analytics, it's pretty stable. It's the curve is flat. Whereas if you look at large language models, and it could be generative AI or GPT, it keeps getting more and more published. And the reason is everybody has access to large language models. The big boys out there like Google and OpenAI and whatnot have invested millions and millions of dollars. They keep getting better. They're multimodal. You can get free open source ones. So it's no surprise in a way that that's the shiny object in the room. And it's really able to do an amazing things with zero-shot learning, which means you're not given an example. I'll show you an example where it analyzes an image with no instruction other than analyze this. I don't tell them what it is. So that's zero shot. So how did predictive AI do in radiology, since most of predictive AI was in radiology? So this is a systematic review, and there are not many of those in this field, by the way. But basically, I would have to say the jury's out a little bit, that in some areas it did as well as a physician, rarely better. It generally did better than house staff, let's say, but it was not perfect by any means. And as a result of that, and this is the latest data I can find, and I don't have anything better than that only 30% of radiologists use AI clinically, and over 70% have no plans to pay for it. And so there's skepticism in the radiology world, which is not totally surprising. But I remind people of the saying, you won't be replaced by AI, you'll be replaced by a radiologist who understands AI. Now, this is just one example of predicted I thought was cool. It was only a couple of months. It was published from Yale, where they identified Marfan syndrome just using facial image. Now, I've done that with children, combining facial recognition plus genomics, but this was new and it raises interesting questions about other diseases, so it was quite accurate. So let's talk about large language models for a minute. And it again started with ChatGPT 3.5. Actually, OpenAI started considerably earlier than that, but everybody sets their clock November 2022. And we're now up to 4.0 latest. You have to use that word latest. That's the name of the model. But there are tiny, small, and medium-sized large language models. Even though they have not really been trained specifically on medicine, they're not a biomedical large language model, they do surprisingly well. And so there are biomedical large language models, but so little is published. Google may have the most promising one called MedGemini. They are good for coding and biomedical data analytics, but there are errors. In the workshop, I will demonstrate one that I think deserves a B+ that does a very good job with data analytics called Visley. But they excel in administrative tasks, creating outlines, writing letters, lessons planned, brainstorming, and so forth. So this is just some of the biomedical large language models, but stay tuned. People are not publishing much about them, I'm sorry to say, so it's a little hard for me to say they're definitely going to be better than the current big large language models. But a caveat here that small language models have advantages. Everybody thinks, well, I got to go to GPT-4 or Claude 3.5 or Llama 3.1. The answer is no, you don't, particularly for administrative. You can get an open source large language model, put it on your local server, and use techniques like RAG. And RAG, I'll tell you about RAG in a minute, but it's more secure, more affordable, faster, a lot of advantages, if you will. Also, this one, I'm not going to spend a whole lot of time, but understand that a lot of people early on said, I don't think large language models can reason at all because their whole role is to predict the next word using linear algebra, basically. But the answer is that's not true. They do reason, and particularly with inductive reasoning, from starting with a simple case and expanding that, generalizing that to a bigger more possibilities. And that raises the other important point, which is underlined, is this is why giving examples in your prompt is important. A lot of us don't do that, but there are many techniques in prompt engineering to write a better prompt to get better result, but one of which is to include examples. Okay, what is RAG? Retrieval Augmented Generation. Well, one of the reasons large language models hallucinate is they're faking it. They don't know the answer, so they come up with something that's plausible. Well, what if, let's say, and I'm going to cite an example here in a minute with Dr. Sterling. He's in the world of liver disease, non-invasive liver disease detection, and so forth, assessment. He has two very long guidelines. They're expert guidelines. But what if you could use that very specific guideline and have the language model trained generally, which already is done, but be able to refer to these guidelines? Suddenly it's way smarter, okay? And the three examples, one is I fed it my last textbook, a PDF, so now it's a textbook tutor. It can answer questions about the textbook. How do you deal with missing data, for instance? Second one is we created a medical review GPT that will review manuscripts to look for errors. Did you discuss sample size? Did you deal with missing data? So that's two uses. The third one I just alluded to that I'll go over in the workshop is using creating a chatbot for a complicated topic that's very specific. But again, it's one of the ideas behind it in the program that I'm going to introduce is you can create one for $20 and then you don't need the subscription any longer. You can make it public. So these are, most of these are public. The one I created for Dr. Sterling is public. This is just an example of the importance of this. This is where they wanted a chatbot to answer oncology questions for common tumors. And but what they did is they front-end loaded one with guidelines, oncology guidelines, and then one without, so to speak. And the answer was the RAG technique was way more accurate, 84% versus 57%. So I think that's relevant. Okay, portal messages. It does a good job of looking at messages, understanding them, and responding. Overall, it's actually longer and more empathetic than the average physician, according to a study at Stanford. But again, I don't think the large language model has burnout or it doesn't interfere with their pajama time. So no surprise there, I don't think. So the problem is that there's not really any good evidence that they save time because you need a human in the loop that edits and looks at that. So far, they do a good job, but I'm not sure they're going to be in your workflow. But I mentioned a last article by Harzan. He took a different approach where all he wanted to do is categorize the portal messages into like needs a refill, urgent, whatever it happens to be. That saved a lot of time, and they did a prospective study, and they verified how accurate it was. So I'm just sort of dropping that hint. That's something MCV/VCU could do. And all these references are hyperlinked if you get the PowerPoint. Ambient scribes, a hot topic. In fact, if you look at the last line, notice how many companies are in that space. Everybody wants your dollar. The biggest one is the first one, is the Nuance product, DAX Copilot, which is part of Dragon Medical One. Here again, it's been fairly well received nationwide. However, when you look at the first two studies, one using Nuance, the next one Nabla, there was no time saving overall. The third study that was at MGH used, again, Nuance product and showed a decrease in time of only 5 minutes, though, but notice the standard deviation of 16.4. So there are some people that it was longer and some people shorter. So the other thing I mentioned before this morning was I'm happy to say that the Mayo Clinic, along with Abridge and Epic, are trying to do the same ambient vendor for nurses, and that's hugely important. All right, just a couple of gee whizzers. Here is a case where I uploaded an audiogram, but all I said is interpret. I said nothing else. I didn't tell it was an audiogram. I didn't tell it was abnormal. So it's able to interpret that. I did that with a medical box plot of data. I did that with a pulmonary function test. Comes back, yep, patient has a moderate obstructive defect. No instruction other than interpret. Here's an example of, this happens to be a colon biopsy. I just said interpret. And so it knows it's malignant. And again, I should have gone back and given it a whole lot more history and see what it would do. But the whole purpose of this is just to show here is a model, a large language model that has not been trained specifically on colon cancer. All right, so this is another systematic review and meta-analysis on diagnostic abilities of large language models. There's always a criticism when you look at these studies in total of, are they biased? What about the methodology and so forth? And to make a long story short, often it's small sample sizes that may not deal with live patients. And so they overall, in the realm of diagnostic ability or clinical decision support, they didn't do all that well. And I'll leave it at that. And then just sort of a little break or humor. I don't know whether you all are on the right side there of please don't make me go this way or not. All right, let's talk about a little bit of large language models and research. I could spend an hour just on this topic, but one of the things I do a lot is research articles over and over again. So now, I mean, you can use ChatGPT 4.0 to summarize an article. You could use any of them. However, these are better. These are designed to evaluate scientific articles. And I'll actually demo Sci Summary. I think you'll like it. It uses Semantic Scholar instead of PubMed or Google Scholar. It's affordable, and it can do some amazing things like uploading. You can summarize 25 articles, and it'll give you a summary. It'll generate an abstract. It'll do all kinds of things. SciSpace has some interesting options you can see there. But just be aware that this is a step forward in our ability to summarize. Here is an example, for instance, where the query, the prompt was trying to look for literature. So this is, again, a Semantic Scholar search for articles, large language models, and physician documentation. They found 207 hits, probably not all of them relevant. But what it did first was to summarize the 207, and notice it said, and as I recall, that it had to be a 2024 article and had to be associated with a PDF. So I narrowed the search. But you notice that you now have like Yan 2024. You can click on that and it'll take you to the reference which is down below. And you can mine the references. You can, in other words, you can upload the references and chat with the references. Again, I'll demonstrate that later. Other research tools, Consensus AI is kind of an interesting one, where let's say you have an ongoing scenario where you're trying to compare two things. What it'll do is it'll do all the literature pro, all the literature con, and then give you a consensus. And it has a very detailed filter, the most detailed filter I've ever seen. So that's fairly interesting. Elicit is more like what I just told you about Sci Summary and SciSpace. PaperTalk.io and ResearchKick have interesting things in terms of helping you come up with research ideas and telling you about gaps in research, which could come in handy as junior investigators and whatnot. And then lastly, GoatStack AI will send you daily, weekly, or bi-weekly newsletters summarizing articles. And I think Archive gets 1,000 articles a day, I think is what I heard. By the way, the reason that's called Archive is X is Chi and Latin or Greek, one or the other. So soon they'll add PubMed. And again, it's a way to expedite research. This is just an example of what I'll present this afternoon, where you use natural language, human language in a prompt to analyze data. You can see Python code if you want to, but you can do the whole thing without any Python if you like. So here, for instance, I just said, give me a correlation matrix and a heat map. And within a few seconds, that's what it generated. Now, in terms of AI and drug research, the sky's the limit because you could use AI early in selecting patients who are good candidates for drugs, all the way to the end to marketing and every step in between. On the left, I mentioned that MIT used it to develop a new antibiotic, halicin, to treat drug-resistant bacteria, which is really important. The second thing is, how about repurposing old drugs that are around? That's also very important. And so those are two major categories we hope AI will help with. And then that brings up AlphaFold 3, which predicts the protein folds, which used to take weeks and weeks and weeks. Now it does it very quickly. But what's different with 3 is it shows the interaction of DNA, RNA, and ligands with the protein folds. So that's definitely a step forward. Large language models in education. Who uses open evidence? All right. I only learned about it about 10 days ago. I'll be honest, I'm dumbfounded. I didn't know about it. It's basically out of MIT and Harvard. It's free to use. I find it really good. It scored 90% on US MLE test. It's well referenced. When you see each reference, there's a box that says detail. It then will give you a summary of that reference using AI, which is helpful. And then below at the bottom, as many of the large language models, it gives you additional questions you can ask that are related. So I just think for quick answers, one of the things I haven't done, have you put in clinical scenarios to see if it would identify?
Ask questions.
Yeah, okay. So what I'm saying is, I don't know if you could put in this 30-year-old lady, ODs, blah, blah, blahs in the emergency room and give all vital signs, all that, and what it analyzes, I have no idea. Yeah, that's not what it's intended for. Second of all, anybody use Glass Health? So that's interesting because its sole purpose is to generate a first-class differential diagnosis and treatment plan. It's created by a physician. It's run, advisory board, all the other people are physicians. So it uses clinical practice guidelines and top evidence as we know it. And it also integrates with electronic health records. So I do recommend it. I don't know that it'll answer every issue or come up with every differential diagnosis. All right, large language models in medicine summary. They're great for administrative tasks. And they may simplify medical reports. That's hyperlinked to an article, and the reason is, with the Cures Act, you're theoretically supposed to give the patient a copy of everything, but as well as I do, for like imaging reports and lab reports, they're not going to have a clue what that means. But with AI, you can generate a report at a 10th grade level, let's say. They do well in medical questioning overall. Great potential for research pharmacology and I think education. They have limited potential in clinical decision support. They're good, very good at listing multiple differential diagnoses, but where they fall down is if you ask them to pick the number one, often they can't do it. They miss it. But often if you have a rare disease and you input the clinical scenario and phenotype typical information, it will give you a decent differential diagnosis. So there's just an example of how far we've gone with USMLE questions in terms of accuracy. All right, let's talk about the challenges. There's plenty of them. It's a huge carbon footprint. I'm sure in a satellite you could get a heat signature over any data center or server farm. Look at the cost to train GPT-4, and now they're working on 5. Also, look at the amount of water they consume. So it's a huge thing. How sustainable are they is the question. And that's why the smaller language models, I think, again, are important. Data privacy security is always an issue. Bias is always an issue based on what data did it train on is incredibly. Is the result interpretable or is it a black box? And one of the problems with AI, hallucinations, when it creates incorrect but believable facts, and keep in mind the references can be the same. Also, I worry a little bit about intellectual complacency, particularly with GPT-5. Are people going to go, that AI said that, and never second guess it or look beyond it? It could be misused. Obviously, we're going to see in this presidential campaign, fake audio, videos, you name it. It, again, may not be good for specific niches in medicine, but you can fine tune a model and you can use the RAG technique, which is really easy. And then you've got a model that works much better. Ethical considerations, cost. Boy, when you read an article, how many of you have seen the cost of the AI? It's never mentioned. And so whether you rent it as a service, and what happens when your favorite startup, and I have several which I've already mentioned, the seed money and the venture capital disappears. What now? You know, what are they going to charge, or are they going to go under? So there are trust issues, security issues, legal issues, maintenance. Remember, many of these large language models are 6 months old on the data trained on. So they're not always current. Some surprises, and I like this, and I'm almost done, is when we did actually it was the first FDA-approved AI-related device specifically for diabetic retinopathy. But who would have thought shortly after that they would be able to predict age, hypertension, smoking, and gender? We still don't know exactly how that happened. Predict atrial fibrillation studies out of the Mayo Clinic from a 12-lead normal EKG. Again, pretty sensitive, but not very precise. And I put in there, and again, come to the workshop and I explain why all this is important for physicians, where they need to know false positives and true positives. So too many false positives, same with an Apple Watch. So they were able to predict age and gender from a routine EKG. How did they do that? Predict left ventricular dysfunction from a routine EKG. This was done by pairing EKGs and echoes on 45,000 patients. Here, the sensitivity, specificity, and whatnot was pretty good, is a matter of fact. Predict race from images. That was a shocker from a chest X-ray, and also from CT, mammography, and other imaging. But it raises HIPAA issues, because if I get a retinal image on you, an EKG, and a chest X-ray, I might be able to identify who you are, theoretically. So other one, predict diabetes. The other thing, predict cardiac function and valvular disease. That's mind-boggling exactly. How does it predict mitral regurgitation? I don't know the answer. All right, I think this is next to last. So what I did is, have you all heard started off the triple aim of medicine and the quadruple aim of medicine and the quintuple aim of medicine? On the left are the aims, okay? And so my question was, what's the potential of AI? What's the current state? And then comments. And so the point is, I think the potential is considerable. I have cautious optimism. But the current state is they're not delivering just yet, but they continue to get better. So you can read on the comments about what may occur as they improve, particularly, for instance, administrative medicine. So my conclusions: AI is needed in medicine because the information exceeds human comprehension, and adding genomic information only makes it worse, in a sense, more complicated. We need to leverage information that's hidden in the electronic health record. I think medical research today benefits greatly from AI and pharmacology. So for the foreseeable future, AI will not replace humans, but there must be a human in the loop. So to quote President Reagan, trust but verify. So artificial intelligence is a game changer, but does have some clear-cut challenges. But in my opinion, healthcare professionals here and elsewhere need to be AI ready. So I think I accomplished the time goal here. These are quotes that I like. I was surprised to see Leonardo da Vinci talk about being a hands-on guy. But those are my contact, that's my contact information. Please feel free to text me or email me. So I'll be happy to entertain any questions.
Thank you, Dr. Starting with some questions here, just for everybody, we have like almost 90, 95 accounts online, so there's probably close to 120, 130 people online. So let's start with some questions here. If you could repeat the question, because I don't think there's microphones in the audience.
Okay, Fadi?
Thank you. So, Dr. Hoyt, again, thank you so much for being here and sharing your wisdom on AI in medicine with us. Very, very nice, superb overview of the field. You said something that really caught my attention, and about radiologists, as a specific example, that you will not be replaced, but you will be replaced with a radiologist who understands AI. Now, this is a really interesting comment, and for the audience, we have a lot of residents, fellows, and for our junior faculty, although this would apply to everyone. What is your advice based on your knowledge, seeing this field evolve, on how to get started and to be competitive moving forward in medicine overall?
Well, to repeat the question is, if it's true that physicians need to be AI ready, how do you accomplish that? And that's part of the reason I'm here, to be perfectly honest, is to look at what the choices are in terms of education. You certainly need some AI champions in the faculty. You certainly need to probably have at bare minimum some electives in data science and AI. Whether you need a course, a structured course for 4 years of medical school is to be determined. And by the way, most centers don't know what to do with this topic. So don't feel bad that VCU doesn't this minute have a solution or a game plan, but you now have a new chief of AI and data with Alok Chaudhry here. You've got a CMIO that's new. I mean, I think you've got good pieces of the puzzle in place, but I do say you can not hide from AI. I don't think everybody has to be an expert, but I think you need AI champions. And I have put together a PowerPoint on AI and education about training, about how you might go about this. It's not easy to carve out extra time and busy schedule when you have clinical responsibilities. But that's, again, part of the reason I'm here, to try to help sort through that.
You cited many articles, and some of them I noticed had a training data set and a test data set. The marketing one said 80%, 20%. One of the problems I've read about is when you use generative AI to do unbelievable things, like you can tell the age of PCP or whatever, but you have no idea how it did it. Often when you use a totally different data set, it's not reproducible because there are hidden things that it's cluing on that actually give it away that we don't know about. And so we can comment on that problem with publication. Like when people publish AI stuff and it does amazing things, the journal editors and the reviewers may not know how to, what the investigators did do. And when the whole way it did it is a mystery, I feel like we're vulnerable.
No, it's an excellent question. The question is, with generative AI publications, they really don't split the data into training and test. They just publish the result. How do you deal with that? Because early on, the predictive analytics, in fact, did that. They usually split the data set, trained, and then tested on a smaller, say, 20% test. That this is one of the black box problems, I think, with generative AI, and I think editors are going to have to deal with that, and national societies are going to have to deal with it. The literature is not very good. I've already pointed out that people tend to report whatever the best statistic is, like AUC, but fail to report others. I don't have an answer. It's an excellent question of how do you validate something where you don't really know how it came with that. Now, I think, though, one of the things we talked about is training AI to tell us what it did. We haven't done that yet. But the point is, I think we may get to a point where the AI is smart enough that it'll actually tell you how it came up with that answer. That's my hope.
And now we're gonna make it up.
Right. And we won't know whether it faked it or not. Other questions? Yes, sir.
I will preface by saying this is coming from a need, right? So there's a wonderful piece in the New York Times about our education system has changed in dangerous ways. Their quotes in the past, the educated person, I'll go back to then, was a scientist and an artist, an architect, and a mathematician. And we have further focused that to just be a very narrow thing. So education quickly became a conduit of social mobility, not a way to be fixed, right? That illuminating this in society. My concern with this is how we are going to regulate the impact in education. I worry that in the process of using it as an actual tool, we may say it's no longer need to learn math. Or we no longer need to study the humanities. Or we need to study how to create a right algorithm. You would tell us what the answer is. When I read applications, for example, I'm excited by the English speaker, but I have to will this make us a very focused society around information algorithms and not about information? How do we regulate?
Yeah, that's an excellent question. Dean Saavedra was asking about how do we prevent intellectual complacency or our own ignorance if we overly rely on AI. I think everybody's worried about that, and the worry will only increase with better large language models with GPT-5, where we say, well, it makes very few mistakes. I do worry about the intellectual complacency aspect of it, even with creating images, across the board. I mean, there's certain things like its ability to create an outline. You say, I want an outline of a course. It'll do a good job, and that saves you time. But it's sort of a sacred art when you deal with a patient to understand. And of course, the large language model can't look at you at your eyes, can't sense that you're in stress. It can't feel anything. So it misses out on all the visual and verbal, both clues. It won't pick up on a depressed patient. However, my buddies that believe AI will do everything and say, oh, it'll look at your face and it'll tell you your patient's stressed today, maybe. But I share your concern across the board, and I worry that as AI gets better, we may get worse.
Exactly the point.
Yeah.
And so my follow-up, maybe it's a comment, is we look at the history of how they are regulated the World Wide Web. That is the case, right? For this second issue as a society, and not as a country, but as a society, I'm willing to say we don't need someone really better than us.
We'll have to see how it pans out. I mean, the bad thing is it's happening so quickly, it almost doesn't give us enough time to think about it. So, but that's part of the reason of having this talk, is so people are sensitized to what they may be looking at here in short order, is they may be forced to make decisions of how much AI do you want, because what's the downstream effect of it? And I share your concern. Other questions? We got 4 minutes theoretically. And then the bouncer shows up.
Go ahead.
Yes, thank you very much for the talk. On your list of things to be alert to and concerned about, the ones that bother me the most are hallucinations and complacency. So my question is about hallucinations. I spend a lot of my time digging for information in electronic records of patients that I've never met. And I find that we put a lot of bad information into our electronic records. I am worried that the computer will take the bad information at face value and lead us down an incorrect path. And then us being complacent, accepting that and making mistakes about the issue.
We're already doing it, unfortunately. Copy note forward, that's an example of it. Yeah, no, I mean, I've been a big advocate, and I'll repeat the question, Are we worried about, for instance, AI reviewing a medical record when the record is erroneous? Will that just be transmitted and continued? The answer is yes. But we're already doing it, unfortunately. I started to say, I've been a big advocate of embedding AI into electronic health record until one of the people in an audience said, yeah, but it's garbage. He says, I don't trust my own electronic health record. So, again, how are we going to clean that up? So, because I mean, it has great potential of summarizing a patient longitudinally and making recommendations. Potential is huge. Or doing it either at the individual level or at a group level or whatever. But if the information in electronic health record is erroneous, we're in trouble. Now, it could conceivably point out inconsistencies, though. The age over here is 58, over here is 54. I could see it doing that and being helpful. But you could just see how somebody would dictate something, not bother to scrutinize it, so there's an obvious error in the diagnosis or what the patient said, and the next person does copy forward, and it gets perpetuated forever. Wow, that's a very legitimate concern, and I don't have an answer.
Are the tools smart enough to detect our stupidity?
I mean, I think that they are definitely smart enough to compare A and B, meaning they can look at the record and point out inconsistencies, but I don't see them necessarily pointing out errors. If it thinks that a doctor dictated that the patient was 120 days pregnant, or you pick something outlandish, it'll just get continued, I think. And so I don't know what the answer is at this point. Well, it's an excellent question. Other questions? And again, feel free to contact me. Happy to answer any questions or concerns down the road. Okay.
Thank you so much.
Good.